Hello, my name's Joshua Hitch. I'm a clinical educator, and today I'm going to be giving you a little bit of an introduction into the NMC Test of Competence Part 2. It's a requirement for all overseas nurses to pass this in order to gain an NMC registration. So today we'll be looking at the implementation station and the requirements you need to fulfill in order to pass this station. So, the learning outcomes for today's session. So, by the end of the session, you will have explored the principles of safe medicine administration and the management of medicine administration. Hopefully, you all have some familiarity with the rights of medication administration, but for those who don't, you should be able to explain what the rights of medication administration are and understand the relevance that these have to your OSCE station. You will have an understanding of the requirements that you need to complete in order to pass this station. So in order to pass the implementation station, hopefully this session will give you that understanding. And you will be familiar with the medication charts and be able to discuss how to document medications that you give, as well as medications that you omit on the medication charts which are provided for the implementation station at OSCE. Now, we won't cover this outcome during this 1 hour lecture. However, we will cover this part of the learning outcome when you come in for your classroom-based session. We'll give you a demonstration, and then you'll have opportunities throughout the programme to practice the implementation station in a safe environment. You'll be able to explain the common mistakes on the implementation station and the strategies which you can use in order to prevent such mistakes. So moving on to the station overview. So the station itself is 15 minutes in length, and you get an additional 1 minute to pre-read your scenario before entering your station. This is the picture on the screen, is what the station looks like during your practice. It looks fairly similar at OSCE, but there is some slight differences. Now, before you start your station, the examiner will give you the opportunity to clarify anything that you are unsure of. This is a good time, particularly if you've got questions, to ask these questions as well, and also to look at the environment that you're entering and just make sure you're happy with the equipment that's provided, and if you're not, raising them concerns to your examiner. The station is a mannequin-based station, therefore the examiner will play the voice of the patient. So as you go through your medication charts, explaining what the medicines are for to your patient, the examiner will respond for your patient. If, for instance, your patient's on antihypertensive, so blood pressure medication, or they're on oxygen, and you wish to know what their oxygen levels are or their blood pressure is, the examiner will give you this information as well if you ask for it. Now, you don't need to wash your hands on this station if your hands are visibly clean. However, you are expected, as in your assessment station, to hand gel on approach and hand gel when you leave the patient's bedside. Now, you should read through your medication chart thoroughly, and as you read through, read each section out loud. This way the examiner can hear what you're reading and understand that you are acknowledging what's on the drug chart. And you should state all the elements of the prescription chart, including what the medication is for. So you must sign the chart appropriately for all drugs that you've given and omitted, and we'll go through later on during this presentation and lecture how you document on the charts. And it goes without saying really that you should treat the mannequin as you would, and the scenario as you would in a real practice situation. So treating a patient with care, compassion, and listening to their concerns if they've got concerns. Now your examiner it's also important to listen to what the information the examiner gives to you before you start the station, because they'll tell you what to do with things like the medications once you've dispensed them before leaving your station. So they'll give you instructions on that. So, a quick tour of the safe handling and administration of medications. So when we think about this, all registered professionals who come into contact with medications as part of their daily job have that professional responsibility to maintain the safe handling and disposal of medications where applicable in order to safeguard our patients. And this also comes back down to your institutions as well. They also have that responsibility to ensure certain criteria met to safeguard and protect you as a professional, but also to protect your patients from harm. So what does this mean? So essentially it's about us complying with local and national policies which have been put in place, complying with the procedures and guidelines that have been put into place locally and by our institutions where we work around the safe handling, the safe prescribing, supply, administration and the disposal of medications. And that these procedures and guidelines are regularly reviewed and updated to the latest best clinical practice. It's about ensuring our staff have the correct training around medication administration, medication disposal, and the general safe handling of medicine administration. It's about ensuring that these medicines are stored appropriately and safely in a medicine trolley or cupboard when not in use, and that these medicine trolleys and cupboards are also clean and tidy from clutter, in order to reduce the risk of error and harm to patients within our care. It is also important to ensure these trolleys and cupboards are locked and secured when not being used, in order to maintain patient safety within the clinical environment. It's about medicines being stored at the correct temperature in order to prevent their structure degrading or becoming damaged. It's ensuring that when we administer medications, we do so according to the rights of medicine administration, and we'll talk more on this on a future slide. It's ensuring that we dispose of medicines correctly. Now, this will vary depending on the organisation in which you are working in. However, it should be dictated and documented within local policy, so easy to find. The rights of medication administration. Essentially, these are the checks any healthcare professional involved with either the prescription, administration, or preparing of medication should adhere to. Currently, there are 8 main rights to consider, and these are: the right patient. It is the responsibility of the candidate to ensure they have the correct patient prior to administering medications within your OSCE. This is done by asking the patient to confirm out loud their name and date of birth, whilst checking simultaneously that these match the drug chart. If in a hospital setting, you should also confirm the patient's hospital number matches, or in a community setting, ask the patient to confirm their address. That we have the right drug, so ensuring that you've dispensed the correct drug when you are administering your medication. So when you take your drug out of the trolley, checking it against the prescription, ensuring that the medication is in date and it hasn't been tampered with. And also that the medication is suitable for this patient, that there's no contraindications as to why this medication shouldn't be given. The right route. That the medication is prescribed to be given the correct way as recommended by the manufacturer, pharmaceutical guidelines and medicational resources such as the British National Formulary, or BNF as it is also known. This is the same for the right dose and frequency, as well as the right time, However, it is also worth noting to ensure the spacing between each dose is adequate so that not to overdose or underdose the patient. The right reason. Prior to giving or prescribing medication, the reason for which it is needed should be considered thoroughly, ensuring all contraindications are thought of and it meets the patient's health and care needs. The right documentation. The prescription should be legible, stating clearly the drug name, dosage, and the route for which the medication is to be given. The duration and frequency of the medication should also be documented alongside the times and the reason for which the medication is prescribed. The prescription should also be signed by an appropriate qualified physician, and their contact details should be documented in case there are any queries around any of the medications. Once you have given or admitted any of the prescribed medications, this also needs to be documented appropriately as per local policies. And remember, your patient has the right to refuse any medication prescribed. However, we should always do our best to advise the patient in order for them to make the best informed decision around their health and care needs. So, abbreviation. So on your medication charts that you are given at your NMC OSCE Part 2 for the implementation station, you might see various abbreviations on there. And these are some of the common ones. So your subcutaneous routes, traditionally abbreviate down to SC. So if you're got to give insulin, for instance, that will be abbreviated down to SC. Intramuscular IM, your oral medications, PO, intravenous IV, your PR rectum medications, PR, your eye drops, or will be normally just written as eyes. Now, if the patient's prescribed eye drops, the prescriber should also write which eye the medication is to be administered in, and if it's both eyes, should quite clearly state both eyes. Your topical medications, things like your patches, your creams and ointments, and again, with your creams and ointments, there should be written where the cream and ointment is to be applied. And your inhalers, so INH. Some of the frequencies you may see, so once daily OD, once nightly ON, twice a day BD, 3 times a day TDS, 4 times daily QDS. You might also get some time-specific prescriptions. So, for instance, on a PRN medication, you might have paracetamol prescribed 6 hourly. So if you get the time-specific medication, it won't always be clear when the last dose was given, so it's worth checking with the examiner when the last dose was given before you decide to go ahead and administer the medication. And the other one that is quite common is weekly. It's worth noting that for your implementation station, you will only be expected to administer oral medications. However, medication which is prescribed to be given via alternative routes within your implementation station, you will be expected to verbalise what you would do. For example, an intravenous medication, you will get an appropriately trained member of staff to administer this for you. So if we take a closer look at the chart, so this is typically the front of your medication chart on the implementation station at the NMC OSCE test centres. Now we must make sure that all the details on the front are correct and legible, and you should do this out loud. So in this case, when you come to starting when you pick up the chart and once you'd confirmed your ID and explained the purpose of your visit to your patient, you would then proceed to read through the drug chart. So to start off, patient's name, Joe Blogg, patient's date of birth is the 15th of the 1st, 2000, hospital number 0123456, address 28 Donald Duck Lane. And there may be additional information below, so you should again take a minute or so just to make sure you read through that if there is additional information. Again, the details of the patient should be completed at the top of the prescription chart And that's the same all the way through your implementation station. The patient's details on your paper charts should be the same, should be on the top of the chart all the way through. Patient's allergies and sensitivity should also be charted. So if they're allergic to penicillin, it should be quite clear that that's an allergy and what kind of reaction they have. And again, you'll be expected to read from left to right the prescription chart for your patient, and it should be signed by the doctor and dated. You should be confirming that this is correct with the patient at the bedside. Where the patient has no allergies, it should also be quite clear and documented with no known allergies in the allergy section, and it should still be signed by the doctor and dated. You'll also note there's information for prescribers and there's information for nurses administering the medication. Now, you don't have to read every part of the information in this section. You just have to highlight that there's information for prescribers and there's information for nurses administering the medication. Now, we're going to look at the codes in a bit more detail, and these codes that are here are the only acceptable codes for you to use when you're omitting a medication. So, should for any reason you are unable to give your patient the medication, you must ensure that this is documented clearly and correctly. And in order to do this, you should choose the most appropriate code from the list which is provided here. And this should be inserted into the signature box by the relevant time. And you should also sign with your full name next to the due time and complete the omitted section on the back of the chart. So let's look at in a bit more detail. So patient not on ward. So it is kind of as it suggests. So this code should only ever be used if you're unable to give the medication because the patient isn't on the ward. So for your implementation station, you should not be using this code really for the purpose of OSCE. However, you should verbalise what you would do when your patient returns and make every effort to administer the medication on their return, providing it doesn't interfere with the administration of future medications. So code 2, so omitted for clinical reasons. So examples of this could be, and it's not limited to, omitting an antihypertensive medication due to your patient having a low blood pressure. It could be also withholding nephrotoxic medication in a patient with an acute kidney injury, or withholding anti-arrhythmia medication like digoxin due to the patient having a heart rate which isn't acceptable to give, so the heart rate being too low. Most commonly in your OSCE, you'll probably use this if, for instance, your patient has an allergy to something and they've been prescribed a medication which could bring on that anaphylactic or allergic reaction. So again, medicine's not available, so your code 3. Again, it is as described. However, should this be the case in your OSCE, you should verbalise what you're going to do in the event of the medication being not available. So could be ordering the medication from pharmacy or seeing if the medication is available in a nearby ward which you could borrow from so that you can give the patient the medication. As already mentioned, the patient has the right to refuse any medications offered to them. In your OSCE, your patient is unlikely to do this. However, if they do, you should ensure you have explained any risks and consequences of their decision, as well as the benefits of having the medication. So code 5, so nausea and vomiting. So if your patient's feeling nauseous or vomiting, you should inform the patient's doctor or the practitioner who's looking after them, because there may be other routes in which the medication could be prescribed so that to ensure the patient still gets the medication with no delay. There may also be medication that could be prescribed to reduce the nausea and vomiting, so it's important we do inform the patient's medical or surgical team who's looking after them. Illegible or incomplete wrongly prescribed medication, again it kind of is as it's said, but this would cover anything from wrong spelling of medication, information which is missing on the prescription chart such as doctor's bleep, drug frequency or dose, etc. Or just being unable to read the medication because it's been written poorly. So code 7, as along with code 5 really, if we're unable to give medications because the patient has no IV access or they're nil by mouth, in your OSCE station this is unlikely to happen because it's kind of what they're assessing you on. But in clinical practice, if you're unable to give a medication due to this, then we should be alerting the patient's medical team or surgical team, because again there may be other ways in which the medication can be given. We don't want to delay the treatment as much as possible really, so we want to minimise that delay to treatment. And finally, so 9, your other reasons. So example of this could be, and again it's not limited to, the patient having received a stat or PRN medication earlier in the day, and the patient's been prescribed a regular dose, and this hasn't been cancelled for today's dose. And there is other examples of when you might use code 9 as well. So stat medications and oxygen therapy, as well as PRN medications. Before administering sort of stat medications, you should ensure that this is not contraindicated by any other prescribed medication or the patient's condition. So if they're prescribed an antihypertensive, I'm going to use this as an example again, that we check with the examiner what the blood pressure is before we decide whether it's given. So remember, the R's of medicine and administration is key throughout the whole of your implementation station. And again, we should be reading out the prescription. So we have today, date today, time due 12 o'clock, drug name paracetamol, dose 1 gram, route per oral, prescriber signature and bleep number are present, so this is a valid prescription. You would then proceed just to make sure, before you decide to give the stat dose, that the patient isn't prescribed paracetamol anywhere else, or hasn't had a paracetamol earlier in the day, or there's nothing else you can give. And then you would sign. So in this instance it's been signed because the nurse has decided not to give the stat dose. So she's inserted the appropriate code, so she's inserted a 4, so the patient refused the paracetamol, and she's signed it appropriately. So again, with your O2 therapy and your PRN medication, so this should always be prescribed if the patient is receiving oxygen. And it's always good practice, if your patient is receiving oxygen, to check what the O2 saturations are. So you can do this by asking your examiner, can I have the O2 saturations for my patient? You might also want to ask your patient how they feel their breathing is, if they feel the oxygen's helping them. So again, talking to your patient. So Joe, I see you're on oxygen. How are you finding your breathing? And you could also ask your patient whether they've had any symptoms such as wheezing or coughing. And again, with the PRN medications, it's worth noting what else is prescribed before you administer that PRN medication. Now, if the patient is prescribed something on the as required side, so PRN, and you decide not to give it, you just leave the boxes blank, because this is an as required box medication, so you don't need to code an as required medication. Okay. So again, antimicrobials. So as I said earlier, the only medications you will be expected to give during your implementation station are oral medications. So therefore, these are the only ones you will need to sign to say you've given or omitted. If the patient's prescribed an intravenous medication, you would just need to verbalise out loud what you would do. You would explain to the examiner and to the patient, so Joe, you're prescribed, so if they're prescribed, say, amoxicillin intravenously, intravenous amoxicillin. Now, I'm not trained to give IV medications, so I'm going to ask one of my colleagues to come back to prepare this medication and come back and give this for you, and once I've finished a drug round for you, and that will be sufficient for this session. So remember the R's of medicine administration. So if we look at this amoxicillin prescription, so we have amoxicillin, start date is today, the dose is 500 milligrams, the frequency is TDS, so 3 times daily, its route is per oral, its duration is 4 days, and its finish date is in 4 days. It's got a prescriber's signature and bleep number, so therefore it's a valid prescription and meets the requirements, and it's been correctly charted and administered. And you'd be expected to read that prescription out as I've just demonstrated there in your implementation station. And if you look at the drug chart, you'll see that the prescriptions have both been signed by a nurse at 8 o'clock for 6 o'clock for the amoxicillin, and a code's been put in for the trimethoprim. The trimethoprim, you'll see, has been omitted, and the code's been given as a 2 as a clinical indication, and that's because the trimethoprim is contraindicated with methotrexate. So therefore the prescription has been correctly coded as a 2 so that the methotrexate could be given by a nurse later in the day or when it's due. So again, in your implementation station, your patient may have intravenous fluids prescribed, or they might be in situ, so you'll be expected again to read through every aspect. So even if there's nothing prescribed on your intravenous fluid chart, you'd still be expected to acknowledge that section out loud. Now, if the patient is prescribed intravenous fluids, whilst you would not be expected to administer these, you would still be expected to verbalise what you would do. So, for example, intravenous fluid prescription which needs administering, you would ask a trained member of staff to come back and give this, and you should verbalise this PAT plan to the patient as well. If there's intravenous fluids in situ, you would ask a trained member of staff, you would verbalise out loud for a trained member of staff would come back and check this to ensure that these are flowing and the cannula is not tissued. And again, you would verbalise this plan to your patient. So when we look at dispensing the medication, so if your medication comes in a bottle, for instance, you should dispense the medications into the cap as seen in the picture prior to dispensing into the medication paper pots. Now the reason for this is if, for instance, you accidentally tip one too many tablet into the cap, you can pop that back into the box without it being contaminated. Whereas if you pop it into the paper pots, you can't. Medication which comes in the plastic metallic sort of wrapping, which needs splitting, that can be dispensed straight into the pot. Now for Urosky implementation station, they usually use the bottles as sort of demonstrated in these pictures. Now, should you drop a medication on the floor, it does happen from time to time, and that's okay. Just proceed to tell the examiner what you would do in clinical practice for Urosky purposes, that for the time being you'd proceed, but you're going to pick up at the end. So explain what you're going to do in clinical practice should the event occur, and then ensure you dispose of the medication correctly before ending your station. Okay, so if, for instance, you drop the cap of the pot on the floor, examiner, in clinical practice I would pick the cap up and I would decontaminate the cap before replacing the cap onto the bottle. For Urosky purpose, continue to assume I've done this. Okay. So best practice is to dispense each medication into separate pots. So again, as seen on the picture 2. And I would say it's advisable, now in your Urosky itself, your examiner will guide you on where to leave your medications once you've administered them, but I think while you're dispensing them, so that you know which medication is which, it's probably advisable to pop the medication by the bottle behind the paper pot, so you know when you come to administer the medications which medication is which when you explain that to your patient. The other important thing to really recognise when at the dispensing and administering part is that between each medication that you administer, that you check that the patient swallowed each medication before you move on to the next one. Okay, and you can do this quite simply by asking the patient, have you swallowed the medication? Are you happy for me to proceed to give you the next medication? And remember, you will have a BNF available. Okay, so if you're unsure of any medication, you will be expected to look it up, and the examiners, if you don't verbalise to your patient what each medication is for, the examiner may quiz you and ask you what the medication is for and what the side effects of this are. So as you read through your chart, explain to the patient what each medication is for and any that you're unsure of, look up at the time before moving on to the next medication. So you're not expected to know every medication, but you will be expected to work within your limitations and check if you're unsure. So drugs which are not administered, so at the back of the chart, so as well as filling out beside the medication itself, there'll be a section on the back of the chart to document the medications that are not administered. And this is an acceptable, clear, legible documentation of the medications which haven't been administered. Okay. So if we look at the common mistakes in OSCE, so some of the common ones are not completing the ID analogy check prior to starting your medication administration for your patient. And this is really important that you do this to ensure you have the correct patient, and if you don't do this you will automatically fail. So as already discussed earlier, make sure you do your ID analogy check. Another common mistake is not reading the chart properly, so try and get into the habit of reading from left to right and reading the chart out loud. Okay, and this way hopefully you should pick up any mistakes on the chart prior to sort of administering any medications. The signing of the chart prior to administering the medication is a big no-no in your implementation station, and really in practice in general it's a big no-no. We should only be signing medicines that have been administered once the patient has swallowed and taken the medication, or the medication through, the nurse is given the medication through the preferred route which has been prescribed. So not maintaining patient safety throughout the whole of the station. So this could be, for instance, there being other medications on the bedside table, for instance, them not being addressed. It could be administering the wrong dose of medication. It could be not even leaving the patient with the call bell at the end of the station as well. Ensuring your patient is safe throughout the whole of your station is really important. So not checking the expiry date of your medication. So as you're dispensing the medication, as I said earlier, you should be checking the expiry date out loud and of the medication pot, and also confirming what the medication is in the pot. So another big common mistake is the wrong codes are used when the medication is not given. So ensure that you have the correct code when you're admitting the medication, that you choose the most appropriate. And the medication given but not signed for, so this mistake is commonly when candidates run out of time, they forget. However, sometimes it can happen when you've got a bit of time left and you don't check your chart. So if you've got a few minutes left, you've completed the station, you've got a few minutes left, go through your chart page by page just to make sure you've signed everything, and it should be signed at the patient's bedside. And again, the drugs omitted section not completed accurately. So as already sort of gone through and the demonstration on the back of the chart, that's the only acceptable way, and the same as inside the chart. So beside the prescription, the code, and it should be your full name, and on the back, as already discussed, that is the only acceptable way. Vital signs not checked prior to administering the medication, which could sort of have an effect on the patient. So again, it comes back to that maintaining patient safety throughout. So if they're prescribed antihypertensives, check what your patient's blood pressure is. If they're prescribed oxygen or receiving oxygen, check what your patient's oxygen is. If it's a diabetic medication, check what the blood sugar is. Overdose and underdosing the patient with medication. So again, it might be the patient's had a stat dose at 8 o'clock in the morning, and you've come to do the medication around at 12 o'clock, and the stat dose was paracetamol, but it was prescribed 6 hourly. The patient's in pain, and you've proceeded to give the paracetamol. Now, whilst the patient can have paracetamol 4 to 6 hourly, in this instance the prescription is prescribed as 6 hourly. So you just need to make sure that you don't overdose or underdose your patient. And the medication given was contraindicated. So again, as already discussed with previous scenarios and situations, thinking about that. That when you're documenting in your charts, it's not clear and legible. So make sure it's readable. Now, there is probably an endless list of common mistakes, but these are the most common ones. So helpful tips. So if I could give you some tips which would really help with your OSCE implementation station, the advice would be to really remember the hours of medicine administration throughout your whole station. Have them embedded into the back of your mind. Explain to the patient what each medication is for, and ensure you leave that call bell in reach. Okay, so sign the chart once the medication has been administered, and ensure that it is accurate and legible, so it's in the correct box. So you haven't given the medication round hasn't been for 8 o'clock and you've signed in the 12 o'clock box. It's signed in the 8 o'clock box, and then it's clear. Read the chart thoroughly and out loud. It may be easier, as said, to go from left to right. However, whatever works for you. State that the prescription is valid, and if the prescription isn't valid because it's missing, say for instance, doctor's signature, explain why it's not valid. Okay. Check the patient's parameters if they're required. Write in black pen, so it's really important for this station that you write in black pen. And if you have time remaining, double check your chart, as you may have missed something. And if you make a mistake, don't panic, it happens. But verbalise what you would do in clinical practice. Now, although if you make a critical mistake, so giving the patient the wrong drug, it's not going to overturn a fail, but the examiners will take it into account. Okay. So you'll be pleased to know that's the end of the presentation on the implementation station for OSCE. So thank you for listening and taking the time to listen. Now, I'm also well aware that the presentation itself may have raised some questions that you would like answering, or you may need aspects of it clarified. So if I could ask you to write down any questions you may have or anything you need clarified, and when we meet for our classroom session on the implementation station, we can go over this within the class time allocated. If I can also direct you to the link on the screen, just here. Now, to help us prepare and tailor your classroom session, please could I ask that you enter this link into your web browser and answer the questions within it. It's a completely anonymous quiz, but it just helps us understand any areas that we may need to go over again as a group, or and if the presentation itself is adequate enough. Okay, so thank you once again, and I'll see you when we meet for the classroom implementation station.